And so I want to just officially welcome you to the fourth annual Faces of PAD. It's been kind of the brainchild of the VIC team to try to connect the different specialties together in a format here for this community to really drive best care practices. And I think we got some very interesting speakers today. So just to introduce myself, my name is Christopher Lassar. I'm a vascular surgeon. I've been here for 19 years in this town, and I have a passion for working with vascular patients. I like doing with carotid disease and aneurysm disease, and recently really have gotten into the peripheral vascular disease space, trying to do things to save people's ability to walk and to save their limbs if they become threatened. And so, just to get started, this is an accredited event. So there is CME available. 8.25 credit hours of CME are available. This is through the Tennessee Medical Association, and they wanted us to know that they have reviewed all of the speakers and vouched for them, and that there's no specific financial interest that's a conflict. So the speakers won't necessarily have to say that. I do want to thank the presenting sponsors. So the CME event here is a free event for you. Normally we pay for a lot of those hours that we have to get, but that's in direct relation to the sponsoring from our presenting sponsor, CSI, which is our own presenting sponsor, and then BD Medical, Medtronic, and Gore for our platinum sponsors. The gold sponsors are Cordis, Janssen, Phillips, Asahi, Terumo, Inari, Getting, and then Boston Scientific. And we thank them, as well as our silver sponsors, Abbott, MiMedx, Shockwave, US Endovascular, GE, and then Silk Road Medical. And so if it wasn't for them, we wouldn't have the event like this, and the food that's provided, the space that's provided. Again, it's all for their goodwill to the medical community. Please spend some time visiting their booths. It's amazing technology that we use every single day to help patients, and learn a little bit about that. I think it should be a good experience to be able to see that. So I want to just welcome you to Faces of PAD. This is the greatest time for treating patients. We have so much knowledge. We have so much technology at our hands now to be able to change somebody's life. And that's really what it's all about, to being involved in the medical profession. We all can greatly impact peripheral vascular medical care in this region. And the first thing is discovering awareness and understanding what it is and how it affects the different parts of our bodies. This is a continuing medical education program. It's sponsored by Tennessee Medical Association. And we need honest feedback from the participants. And one of the things that happened the last few years was the participants said we need more time to ask questions. We want to be able to ask questions, ask the doctors, the presenters, what's a specific question that they had. And so we've decided to do a little bit different. We have 3 lectures to 4 in each hour session, and then the presenters will be on stage right here, and you can ask any question you like. And that way we can really get that feedback and get everything answered the way we need for our participants here. Please enjoy the course and tell your peers. I think this has grown year over year, and I'm very excited the fact that this is a live event. I mean, it's been crazy that we've had for the last few years, but it's also streamed virtual right now, and all of the sessions are going to be recorded, so if you want to review something, you can do that again. And for people who can't be here, they can review this over the next 3 months and gain the 8.25 CME credit hours. So that is available to people who need to do it that way. One other comment I stated was reach out for help or advice with patient problems. The physicians and the people that speak up here, highly knowledgeable and And they're willing to share their knowledge and help you understand how to take care of patients better. So my first topic is just a kind of a broad topic of PAD syndromes, the big picture, and the state of Tennessee and what's happening. There's an epidemic of PAD that's happening that's really not very clear to most people. It's estimated that 20 million Americans have PAD. And in 2015, 2.5 million people were diagnosed with critical limb insufficiency. That means not enough blood to keep their leg alive. The CLI is the leading cause of major amputation in the US, and the South experiences the worst part of this. 40% of all amputations that happen in the country happen here. And why is that? Well, we have a lot of issues that we need to talk about and discover. PAD is a marker for death with a 1-year mortality or major cardiovascular event rate of 20%. Sometimes we think PAD may not be that bad, but there is some issues that we got to understand. The majority of patients with PAD are asymptomatic or believe their symptoms are related to something else. They have hip pain and they can't walk well, so they blame their hip, but it really may be a circulation problem. And that's what people tend to do. There's an overwhelming majority of patients with PAD that are underdiagnosed and therefore medically undertreated. And so to save someone's life or to extend their life, we have to start to deal with the underlying medical conditions that lead to the complications of PAD. And I think my battery just died. Can you advance the slide, or do you have a different clicker? And that's not the end of the talk, by the way. You don't get off that easy. Here we go. Maybe I just have to push harder. So when we talk about PAD, what does it affect? Well, it's obvious that we've heard of the term claudication, and that is where we have the cramping in the calf, but it can also lead to rest pain, pain at nighttime because of low circulation, or gangrene, as we see at the 6 o'clock position, or possibly embolization syndromes. So those are direct related issues with PAD, but there's also indirect issues. People that develop heart attacks, or people who develop a stroke. It's still the same process of atherosclerosis in the body, aneurysm, or blockages of the renal vascular system or the mesenteric vascular system. These can all affect the vascular system of the body. And then smoking has a direct effect with the patients with PAD, and lung cancer is obviously related to that. So this is a story of a young 30-year-old African-American female who I had the pleasure of meeting. And when I first met her, I would describe her attitude as angry. She was pissed off at the world. And when you start to hear her story, you kind of understand why. She's currently laying in a bed in dialysis, and she's 30 years old. And she has gangrene of her foot. In that right panel, you see her foot has a kind of pink bottom and the black toes at the top. And this is after I revascularized her. I was fortunate enough to get the circulation back into her foot, and I said, we have to wait. We have to let the body demarcate. Tell me what's going to live, what's going to die, and then we'll do surgery to actually save her foot and allow her to continue to walk. And I came back to see her a few weeks later to check her in the dialysis clinic and to see where her progress was. And I said I was really happy about her right foot. And she said, well, what are we going to do with the left foot? And I pulled the cover back, and her foot turned gangrene in the last 4 weeks between my first surgery and then when I was seeing her. And this is a patient that had dialysis 3 times a week. I didn't know. Nobody told me. She didn't call me. There was a breakdown in the system. And she's in big trouble. You know, one of her problems is that she has blood sugars that tend to run about 500 deciliters of glucose, in her blood testing. So she's absolutely uncontrolled diabetic, hypertensive on dialysis, and she's 30 years old, and she's not going to survive. And so no wonder she's angry. But we can do better in this medical community. We have to understand what it is so that we can move forward with this. I'm going to ask for a different remote if you have it, or if you can advance my slide. Is it possible to advance the slide? There we go. So obviously she's in trouble. And so when we think about people with critical limb insufficiency, we want to understand, we know that they're at higher risk of dying. And we wanted to give a sense of how do we make sense of this. And so this is on the bottom row is the number of thousands of patients that have a disease, and this is specifically cancer. And we're looking at the death rate in the 5 years on the y-axis. And when we look at the top, we see pancreatic cancer. And pancreatic cancer, fortunately, is not very common, but it has a very high death rate. And then on the bottom, in the bottom right, we see breast cancer. And breast cancer is more common, much more common, 300,000 patients a year. But the death rate's in that 5 to 10% range. And so when we look at the red dot, that's what critical limb insufficiency patients. So if you have CLI, more people die in 5 years with a diagnosis of CLI than all cancers, except for lung cancer, which has a 3 times increase of a death rate. So it's a highly mortal diagnosis, and we have to understand it. PAD is a marker for death with a 1-year mortality and major cardiovascular event rate of 20%. When we look at who gets it, who has PAD, and we looked at some different trials, in the bottom we see the trial called the Partners trial. The Partners trial brought into anybody, they tested with an ABI, anybody that was over 70 years of age or was over 50 and had diabetes or were a smoker. And what they found was that 29% of that population had PAD. And when they further tested, half of those patients, 44%, had just PAD, but 56% had PAD and coronary artery disease. When we looked at, well, what symptoms did they have? Were they symptomatic or asymptomatic? And what we found that was if they had PAD before that we knew about, 61% had nonspecific symptoms of their PAD, 12% had claudication, which we always kind of tie to PAD, and about 25% had no symptoms. In the newly diagnosed PAD group, about half of those patients had no symptoms. So in that group, about 15%, that whole group, 15% had coronary disease and no symptoms. And so and that's why PAD is something that we have to understand. When we do a basic ABI in the office, if the ABI was 1, the normal death rate over time was shown here at 0.9, but it fell significantly if you had a lower ABI. So that simple blood pressure test of the arm and the leg can predict your mortality based off of just that simple test. So what are the different factors that play into this issue? What do patients do, and how does that affect people? So when we look at the bottom line, the root cause is what we call endothelial dysfunction. Endothelium is the inner lining of all your arteries and your veins. And there are many different things that attack the endothelium. If I were to take your endothelium and lay it out on a field, it would be the size of an Olympic-size soccer field. That's how big it is. And so it really is the largest organ in our body when we think about cell mass. And so over time, the natural process of disease is that we develop a plaque, and by the 3rd or 4th decade, those plaques can actually start to rupture, and that's when we start to get things like heart attacks and strokes, especially in your 5th and 6th decade. Or if we're smokers, and what we see is that about 20% of the country still smoke on a daily basis, and it's different in each group of people, but about 20% is the number that we see. Obesity is an issue, and it's a rising issue. It's a rising issue in not just our adult population, but our children as well. And I saw statistics about a year ago that about 35% of all Tennesseans would classify themselves as having an obesity issue. So it's truly an issue. It's truly an issue in this region. What does that lead to? It leads to the upsurge of type 2 diabetes, and currently 9% of folks in the U.S. have diabetes. About 3% additional are just undiagnosed. And if you are African American or Hispanic, you have a much higher rate, about 18%. So it can affect us all very differently. Hypertension is also a major problem. In Hamilton County, 35% of adults deal with hypertension. That's a major issue. So all these things can affect the endothelium. It can lead to the number 1 cause of death, which is heart attack, the number 5th cause of death in the U.S., which is stroke or leg amputation. And in this region, it's the number 1 cause of death for, which is, again, heart attack, but it's the number 3 cause of death for stroke. So we have an amazing stroke center, but it's too bad we have to have an amazing stroke center but our population needs it. So how do we as a medical community get ahead of this and manage the disease for our patients? At VIC, we had a mission to have victory over amputation. That's been our primary focus over the last 6 years, and this is part of the team that helps me do that. And so why is that? Because we live in the South. And this is a density map of all of the amputations that occur in the country. And you can see in the southern states, we have a tremendous burden of disease that leads to critical limb insufficiency. And this represents the final stage of PAD, or peripheral vascular disease progression. So if we have a patient with critical insufficiency, and we do a major amputation as an option for them, or if we perform a bypass surgery or an endovascular therapy to reopen those arteries, you see in the bottom survival curve that the upper level is where the bypass and the endovascular therapy was, and you can see the death rate for those who had the amputation. And so this suggests strongly that there's an impact of survival if you lose your ability to walk. And that's the reality of things. If you can't walk, you can't stay healthy. If you can't exercise, you can't keep your heart working. So you have to be able to walk, and that's critical to save the leg. So what do we have going on here is a couple problems that I've seen is why do we move to amputation first? And I think we have to change behavior and action. We get results by doing things in a different way, and we're looking for performance. It's really trying to change the mindset. So if we have the mindset that we don't do an amputation for the diagnosis of PAD alone and have that concept, then we can hopefully change this pathway. Currently, the pathway is, in the U.S., is it to limb salvage. We have this great technology. We're going to see all these vendors with all their instruments that we use every day, but that's not really what happens. The majority of amputations most often major amputation is most often the only treatment option offered to patients with CLI. And if a doctor's standing above a patient saying, hey, listen, you need to lose your leg to save your life, well, that's kind of hard to ignore. So, second opinions, I would say it this way, are important. No attempt at revascularization in 60 to 73% of CLI patients currently. No angiograms performed in over 50% of patients with CLI disease, despite a 90% odds reduction of amputation, meaning that if I did an angiogram, 90% of the time, we could do something to actually improve the circulation and hopefully reduce that chance of amputation. So I think the CLI philosophy must change. These are patients that I was referred to in the hospital for amputation. That was why I was consulted. And we've saved most of these patients. What about advanced elderly? I really don't want to be the doctor who amputates the 123-year-old lady's limb. I don't want to be known for that. That's not what I want to do. So just because you're elderly doesn't mean that we can't do something to fix you. Or if you have a contracture, it's difficult to walk, but we can still have people mobile. Sometimes you can't do anything but an amputation. If you have osteomyelitis of the joint or major infection, then we have to lose the limb to save the life. So there's some thoughts that amputations cost less, and that's really not the case. When we've studied this, if you do Endovascular therapy or surgical therapy is around $27,000, and it costs about $40,000 for that amputation. I would tell you, though, the personal cost for patients is much higher. It's on the order of about $100,000 because they have to build ramps in their house. They have to have special things on the wall to hold themselves. If we do some of the work that we do every day in our outpatient endovascular lab, we actually save Medicare about 30%. So this new venue of where we actually do the therapy can actually reduce cost as well. I think the surgical mindset must change. Surgery is amazing, and this is where we have a great impact for patients' lives. And general surgeons are trained to do femoral to popliteal bypass, but they often are not trained to do tibial bypass. That's down at the lower leg. Vascular surgeons, that's where I did my work. We were trained how to do that. And also, interventionalists, cardiologists, radiologists, vascular surgeons can open up arteries in the lower legs with balloons and angioplasties. But oftentimes, if you're going to be very successful, you have to work at the level of the ankle or lower, and that's usually a critical limb specialist that does that type of work. Access to care must change. The red dot is where Chattanooga is. We're looking at North Carolina, and depending on which county you live in North Carolina, depends on what operation you get. So if you are in the wrong county and you don't have a vascular surgeon in your county, there's a 29% higher chance you're going to lose your leg because you live somewhere different from one county to the next. And so we have to change that idea. So how do we as a medical community get ahead of this and manage the disease? I've talked about a community network for critical limb. And what that means is when a patient comes in that's identified with critical disease, primary care is activated, or the interventionalist sees the patient, decides they have critical disease. We have to get the appropriate people together to save the leg first. So that's the interventionalist and the podiatry specialists. And when we do that, we can save that limb. So it's important to promote a sense of urgency. I love this. This was on the billboard a few years back at Erlanger. We're having a brain attack. We're having a stroke. Get to the stroke center. We're having a foot attack. Get to the people who deal with the foot disease, and that way we can get them in the system. And so if you're having problems with feelings of pain or loss of sensation or open sores that don't heal, weakness when walking, if you have a flow problem, we need to get to the appropriate people. You can make it fun, same kind of concept. Are you summer ready? Summer ready for the beach, but do you have a flow problem? It's important to understand. So if we can create a situation where we do limb salvage, we don't do justice to the patient just by saving the leg. We can't just be plumbers and carpenters. We have to deal with the endocrinologic issues, the high sugars, or possibly an infectious problem. But this concept, I think, in this community can really improve not only limb salvage, but improve survival. Secondary interventions, people that have this disease have cardiac issues, and so we need to get them to the cardiologist to be evaluated for possible coronary disease. So I say no more amputation. This is a great conference to help you learn more about what to do and think about this disease and disease process. So thank you very much. The next speaker I'm going to introduce, Dr. Allison Bailey, and the next two speakers are personal heroes of mine, and quite honestly, I've used them in consultation for my own personal health. So if that gives you any idea of what I think of them, I want you to understand that it's in highest regard. Dr. Bailey, she earned her medical degree from the University of Kentucky, and she completed her internal medicine residency at that place. She did her postgraduate fellowship in cardiology at the University of Kentucky as well. And she has been in town probably about 6 years, Allison, I think that's about right. Her most recent endeavor was to launch Centennial Heart at Park Ridge Medical Center. And she has earned her board certificate in advanced heart failure, transplant cardiology, adult echocardiography, cardiovascular disease. She's an internal medicine boarded in advanced cardiac life support. She is a prolific speaker. She speaks all over the nation. She works at the highest levels in her cardiology specialty, and I believe she has an international following as well. I think she actually has a speech today, to the world somewhere else. So we're going to take advantage of this opportunity to have Dr. Bailey speak to us.
Thank you so much. I'm so glad to be back at an actual live meeting. Chris was correct. I am speaking somewhere else later today, but it's virtual internationally, which is not nearly as much fun as seeing all of you here. So I think, first of all, I want to say thank you to Chris and his entire team, because I think this is so important. I'm going to just briefly talk about all of the factors Chris just mentioned that are affecting the health of our patients in this region and really promoting both chronic limb ischemia as well as heart disease, stroke, diabetes, and all the other chronic conditions we're dealing with. So my topic was the amazing human body. How do we live longer well? So I think this is a really important topic. Because, sorry, let me see if I can figure this slide thing out. Okay, thank you. I think it's a really important topic because this is what I try to do for my own health. I don't want to just live a long time. I want to live a long time independent and free of disease and without dementia, without chronic limb ischemia, without heart disease. And so I think it's really, really important that we start thinking about healthy years, not just years alive. Right? Have any of you rounded in the nursing home or seen patients in the nursing home? Who has? Who wants to end up there? None of us do, right? Because it symbolizes sort of the end stage of people who can't take care of themselves, frequently from a combination of comorbid illnesses that have been having an effect for a lifetime. So the key to living longer with a good quality of life and functional capacity, right? I want to be hiking when I'm 85, not lying in a dialysis unit, is prevention. Prevention, prevention, prevention. So we're going to talk about that. If we look at the death rates in the United States, I put females on here, but males look exactly the same. Cardiovascular disease is the #1 cause of death. It kills more people than all forms of cancer combined, as well as the next 5 most common comorbidities all put together. Peripheral arterial disease falls into that category, as well as heart disease and stroke. And in the South, we are very affected by cardiovascular disease. We have the highest rates in the country. I'm going to show you some maps of that, hopefully, in a moment. But we also have some of the highest rates in the world. Our rates of cardiovascular disease in some of the counties in the Southeast are parallel those in the third world, where we really don't have medical care. So the prevalence of cardiovascular disease in adults more than 20 years is 48% overall. So half of us will develop some form of cardiovascular disease in our lifetime. And we really want to work on our lifestyle to prevent that. I'm just going to briefly mention this guideline. This is a primary prevention guideline. So this is from the American College of Cardiology and the American Heart Association. And it's a really nice summary about what we know that prevents heart disease, stroke, peripheral arterial disease, hypertension, aneurysms, all of the things that we're working to fight against. So if you're not familiar with that, I would check it out. And then I just want to say the most important way to prevent ASCVD, atherosclerotic cardiovascular disease, heart failure, AFib, diabetes, is a healthy lifestyle throughout your lifespan. That starts at birth and goes until the day you die. So we got a lot of time. Everyone knows we should discourage tobacco use. That's the only thing I'm going to say about tobacco use, but it is associated with nothing positive. So we should discourage all forms of tobacco use. And then I do want to make a few comments about something Chris mentioned about where we live and how that influences our health. So our life expectancy at birth is strongly influenced by where we're born. Now think about that. That means it's not necessarily our genetics, but it's our environment. It's largely our environment. So you can see this map, and you can see down here in the south, the red is not good. It means that we have a lower life expectancy than people born in other parts of the United States. Mortality is higher in rural areas because largely the things that Chris just said, it depends on the access to health care. And access to health care has historically been poor in rural areas and in urban areas, right? Inner city areas. So you have two dichotomies with different genes, different disease and different prevalence of disease, but the same exact end result, high mortality. And it's dictated by social determinants of health, right? What our educational status is, lack of physician availability, and lack of health insurance. And we struggle with that a lot in Tennessee. So you guys should always think about that when we're trying to take care of our patients, because they frequently don't have access to the same health care you or I may. And it becomes a really important part of how we treat people. Our risk factors are strongly associated with socioeconomic status. So if you look here, as your average family income goes up, your likelihood of having obesity, hypertension, or being a smoker goes down. Okay. And your neighborhood deprivation index predicts your risk factors as well. So if you live in a neighborhood that is socially deprived, meaning low educational levels and low financial stability, it affects everything about your life. So just think about that when we see our patients. We're going to keep going. So when we talk about ideal cardiovascular health, that's what I love to talk about. I'd love to see cardiovascular disease go away and never see patients again. Find some new disease to take care of, but we're a long way from that. When we talk about optimal health factors, we're talking about a total cholesterol less than 200, a blood pressure less than 120/80, fasting glucose less than 100, and no tobacco use. And then we look at why we should care about this. So the Heart Association took all of the data that exists, put it into one document, and came up with this concept of optimal or ideal cardiovascular health. And if you're a woman or a man at age 50 and all of those 7 risk factors are controlled, you have a lifetime risk of symptomatic disease of less than 5%. If you compare that to a woman at age 50 with 2 or more of those risk factors uncontrolled, that jumps up to 50%. And for a man, it jumps up to 70%. So you get a profound reduction in disease. And at age 50, you have a median survival of good, healthy years of more than 40 years if you have optimal cardiovascular health, which is something I strive for. In the United States, we're not doing so great. So this is our graph here. If you look at smoking, we do the best with smoking. About 20 to 30% of our population smokes, and that has decreased over time. But if you look all the way down at that purple line at the bottom, that looks like it's the bottom of the graph, that's healthy diet. So we really do poorly at a healthy diet, and we'll talk about that a little bit. And then if you look at things like physical activity, controlling our cholesterol and body mass index, we don't do so well with those things either. And this is really, really concerning. We've done a great job since the mid-70s at reducing cardiovascular disease rates and death rates. But look what started happening here about 2018. Our numbers are going back up again, and it's affecting younger people, and young women are actually at the highest relative increased rate of cardiovascular disease events. So this is something we all have to keep our eyes on. It has to do with a lot of things. The opioid epidemic is part of it because it created this, there's lots of thoughts about this community of despair. And we know that anxiety, depression, and psychological distress increases your risk of cardiovascular disease. So we know that we can predict your first heart attack, we can predict your first stroke, we can predict if you have peripheral arterial disease, and that's based on the culmination of your risk factors. Here are the most common risk factors, and the one for stroke and PAD looks exactly the same as this graph, but what you see is it's things like smoking, lack of fruits and vegetables and exercise, lipids and abdominal obesity, but look at psychosocial distress. 1/3 of your risk for development of cardiovascular disease, as manifest by a first heart attack, was attributed to anxiety, depression, and stress. And importantly, over 90% of our risk is predictable, therefore we can help prevent it. So largely we're talking about a disease that is mostly modifiable. So all of us in this room can do things to help our patients ourselves and our families and those people we care about by focusing on a healthy lifestyle. So when we look at risk factors, especially in my practice and probably your practice, it's very uncommon to see someone with one risk factor. We know that, and we know that risk factors cluster, and it's because they all increase each other. So for instance, if you have a poor diet, you're more likely to be obese, you're more likely to have high blood pressure, you're more likely to be physically inactive, and all of those things are going to contribute to having increased psychosocial distress. And all in all, this increases our risk for cardiovascular disease more than just one of these risk factors. I got to talk about the blue zones exclusively the last time I was here, and I can't ever give a talk without mentioning the blue zones because it's one of my favorite things. If we look at the blue zones, it's places in the world where people live the longest free of disease. These are the 5 blue zones that were originally described, and Loma Linda, California is the only one in the United States. And so in the blue zones, there are similar lifestyle traits. And I think that becomes really important because geography, culture, and genes are different in all of these blue zones. But these factors that I'm going to tell you about are common in groups who lived long free of disability, which is what I'm hoping for. So there's a whole website about blue zones, there's books, there's all sorts of things, but they call it the Power 9. And so the Power 9 were people moved, they weren't sedentary. They had a purpose in life. They believed in something. They got up every day for a reason. They downshift or reduce stress. The 80% rule, which we've talked about since my child was little, when your belly's 80% full, you stop eating. And that way you get into this lifetime of not overeating. There was a plant slant. Most of these groups of people were plant-based, but not because they woke up and said, I want to save the world by being a vegetarian. It's because eating plant-based is much cheaper and easier in many parts of the world. They had wine at 5 if they drank. So in Loma Linda population had no alcohol. The other groups had small amounts, but it was in a large community setting, not in a dark room by yourself. They belonged to something. Most of these people had a religion that they believed in, and attending one religious service a month was associated with 7 years of additional longevity. 7 years of additional longevity. They had loved ones first, they had people that they wanted to make better, and then the right tribe, meaning that the people they surrounded themselves with did similar things as they did. So quickly, we're going to go through food. Food is very important. With every bite, we can either prevent disease or promote disease. So think about that as you eat the rest of the day. Even Hippocrates knew this a long, long time ago. He said, let food be thy medicine and medicine be thy food. So an optimal diet is appropriate and energy balance first and foremost, meaning if your body mass index is over 25, you need to eat less. It needs to be DASH type, which is low in sodium. It needs to be high in fruits and vegetables. If you eat animals, it needs to contain some fish, fiber-rich whole grains, and minimize sugar-sweetened beverages. The DASH diet is the most studied diet in the world and the most effective, and it is a low-sodium diet, less than 2,300 milligrams in a day, which is about 2/3 of a teaspoon, and less than 1,500 was even better. It was high in fruits, vegetables, whole grains, and low in saturated and trans fats, and then it contained low-fat or fat-free dairy products. And if we look at the association between sodium intake and blood pressure, we can see that even those people who ate the high salt diet, which was 3,000 milligrams, which is still less than the average American, when they went down to 1,500 milligrams, you saw about a 15-point reduction in their blood pressure. Whole food plant-based nutrition I talk to a lot of people about, and what that really means is it's a way of eating. It doesn't mean you're a vegan or a vegetarian. It means you try to stay away from refined and processed foods, which really is the scourge of the modern era. And the majority of foods are plants, grains, and legumes, and you absolutely eliminate processed meats from your diet. Those are associated with increased risk of cardiovascular disease, cancer, basically everything bad. Processed foods should be avoided. If you take this example, if you look at corn, that's not processed. If you look at corn in a can, it's minimally processed. But then if you look at Doritos or any of the other myriad of things that happens with cornmeal, it's ultra processed. And what we know, a recent study that looked at over 40,000 individuals showed that a 10% increase in the proportion of ultra processed food was associated with a 14% higher risk of all-cause mortality. So ultra-processed food should be used as a rare treat, not a daily occurrence. If you're vegetarian, we know that your body mass index is lower, but as you cut out animal products. If you get down to vegan, it's about 5 points lower, and your risk of diabetes and hypertension go down by about 75%. When we look at plant-based diets and heart failure, we see a significantly reduced risk of heart failure when compared to the Southern diet, which is where we live, right? And there's been lots of studies done about this. The Southern diet is the worst dietary profile in the United States, probably the world, and a plant-based diet can reduce lots of risk associated with that, including type 2 diabetes, coronary heart disease, and importantly, red meats associated with increased mortality. So this is from both the health professional study of physicians and the nurses' health study of nurses, which are overall a much healthier population than the general population. And you can see that as your servings of meat per day go up, so does your risk of having mortality. And all-cause mortality, not just cardiovascular, because your risk of colon cancer goes up. And I don't know if anyone's noticed, but colon cancer is happening at younger and younger ages, which is why our screening age just dropped from 50 to 45. 7% of deaths in women could be prevented if all individuals consume less than half a serving per day of red meat. So another thing to think about, if you look at the dietary recommendations, they recommend a wide variety of foods. And these are so much better than the old ones where we really just talked about certain things. So fruits, vegetables, legumes, nuts, whole grains, and unprocessed meats if we're going to eat meat. Physical activity, we are not active in the United States and the world. We should be getting a lot of activity because activity does lots of good things. It not only improves our physical functioning and our mental state, but it reduces our risk of having bad heart rhythms, having heart attacks, having blood clots, almost everything bad you can think of. You have to do it when you first start out, you have to be slow or you'll have an increased risk of orthopedic injuries. But if you look at the United States, the average adult spends about 0.2 hours a day in moderate to vigorous activity compared to 7.5 hours in sedentary behavior. So we've got some work to do. The greatest benefit in physical activity is getting people that go from no activity to some activity. Even if it's from 0 minutes a day to 3 minutes a day, there is benefit in that. And so you don't have to get to that magic 30 minutes. Anything's better than nothing. And again, if you look at the delta benefit, the change in the slope of that graph, it's the strongest with very low levels. If you need to lose weight, high intensity activity, you can get much more benefit for the much less amount of time. If we look at obesity in the United States, you see this graph. The orange is bad. This is non-Hispanic whites. This is non-Hispanic blacks. And this is Hispanics in the United States. Again, the South does not do well with obesity. We know that our risk of diabetes goes up when our BMI is over 25 for both men and women. And we know that if we can lose 5 pounds over 16 years, our cumulative risk factor sum goes down by 40 to 50%. Compared to if we gain 5 pounds over 16 years, it goes up by almost 40% in women and 20% in men. So weight loss is really important because it affects everything else. Hypertension is a really important risk factor, and women tend to have hypertension earlier in life than men. And as we get older, everybody's diastolic blood pressure starts going down, which is not to be of concern when treating systolic hypertension. Home blood pressure is far and away the most important and the only one that correlates with outcomes reliably. So office and 24-hour blood pressures don't correlate nearly as well, so every patient should be encouraged to get a home blood pressure monitor that has office-based hypertension. Our optimal blood pressure is less than 120/80. By the time we go from 115 to 135, our cardiovascular death rate doubles. When we go up to 155, it's 4 times higher, and by the time we get up to 175, it's 8 times higher. So it's really, really important risk factor that largely causes no symptoms that we need to control. And this just looks at a woman who had a blood pressure of 130 to 139. You can see her risk is considerably higher than someone who is less than 120/80. If we lose weight, about 15% body weight correlates with about 10% reduction in blood pressure. So for many people, weight loss is effective. If you do a normal body mass index, get daily activity, and follow a low sodium diet, you have about half the risk of developing hypertension as someone who doesn't do those things. Non-pharmacologic interventions are the ones we just talked about. What is normal cholesterol? I think this is really important. I know there's cholesterol talk, so I just have to briefly mention this. But if you look at human hunter-gatherers, people who do not live in industrialized worlds like the United States, adults rarely have a mean cholesterol above 150. Their LDL tends to be in this 50 to 75 range, which is where we land on as the number needed to prevent progression of atherosclerosis. Our guidelines say less than 70 in the United States for secondary prevention. In Europe, it's less than 55. The average American has a total cholesterol of 190. And so this 50 to 75 range becomes really important. And so over the years, we've probably evolved into a group of people that don't metabolize cholesterol the way we should. And this becomes important because your cumulative LDL years predict when you'll develop plaque. So if you have a high LDL your entire lifespan, you're much more likely to develop disease than someone with a low LDL. And it doesn't matter how you get your LDL down, whether it's diet, whether it's any of these myriad of drugs, you see lower vascular event rates. So non-pharmacologic interventions are great for lowering LDL. Keeping a normal weight, a normal blood sugar level, reducing refined carbs and simple sugars, and exercising are great first steps to improving lipid levels. And you really have to individualize treatment goals based on whether you're low risk or whether you have established disease. If you have established atherosclerotic disease, that's a very different group of people. Eating a high-fiber diet will lower your LDL, having some nuts will lower your LDL, and replacing some meat protein that's high in saturated fat with vegetable protein will lower your LDL. Putting all this together, improving lifestyle improves multiple cardiovascular risk factors. So stay active, eat mostly plants and whole foods, and stay away from processed meat and ultra-processed convenience foods. Watch your weight and your waistline, and follow with a clinician for optimal prevention. So prevention really is key. Everybody needs a primary care provider. This is a diagram from the AFib guidelines, which I think is so important because it points out the importance of a team, which is what Chris just alluded to, and that's really what most of our patients are missing. They don't have the team that focuses on prevention. And so we really need to focus more on team-based care. Thank you very much, and if anybody has any questions, there is my email and my Twitter address.
Yeah, thank you, Allison. That was amazing, as I expected. So many different things to think about. I guess my personal list has gotten longer of things to do. But next I want to introduce Ed Jones, who's well known in this region. He is the owner of Nutrition World, and this has been, I think, almost 20 years now, Ed. I might be wrong on the number. But he's earned his a degree in 2002 from the American Health Science University in Holistic Nutritional Training. And a lot of our patients believe that food is medicine, and Ed is one of the proponents of that. And we wanted to get his thoughts, insights, and experience from the clinical side of what he does every single day in counseling doctors, as myself, and many of the patients that come to your offices. He's a professional member of the American Botanical Council. He is elected member of the American College of Nutrition in 2014, active member in the Vitamin D Council, a member of the Functional Medicine Group, and holds a certificate in completion of the German New Medicine, and a member of the Pastoral Medical Association. So I guess not only do we talk to patients about how to stay healthy, but we also have to counsel them in the psychological aspects of our life and how we do things. So Ed, please come and enlighten us.
Thank you to everyone. I'm honored to be here. This will be my third time speaking, and just personal story a little bit. This all started my whole life journey about 1967. I was 10 years old. I lived with my father. My mother had passed away, and my father was a smoker, big-time coffee drinker, and lived on sugar. But for some reason, he invited a Shackley salesman to come to our house. I was 10. And I'll never, ever forget the time when she sat there and said, food is medicine. Food prevents disease. Food and nutrition can actually help take care of health problems. And that was the beginning of my journey. Now, 54 years later, here I am. And I am honored that I have lived such a passionate, fulfilling life. All this is just life history. And in fact, Dr. Lassar said earlier today that he was glad that I can share my 50 years of life experience. The three things I'm most proud of that I'm doing right now is I have a podcast called The Holistic Navigator. I have 102 episodes on there at this point, and it's not there to treat patients. I can't legally do that. It's there to empower people so they can be healthier. It is rated in the top 1% of the podcasts globally in the world, so I'm very proud of that. Second thing I'm proud of is Vital Health Radio. I'm in there with Dr. Green every Sunday morning, been doing it 3.5 years, sponsored by a hospital. What they wanted to do is bring in the two worlds of, I won't say conservative, but traditional thinking with my, whatever you call what I do. What used to be called alternative, nutritional, integrative, I don't care what it's called. But we've blended hands, and that's why I'm here today. It's because I want to expose maybe some things that you are not aware of, because 33% of your patients are coming to my store, at least that, and they may not be telling you what they're doing. We need to partner on this, not be separate entities. And the last thing is that I started with my passion of developing a wellness clinic. We have 17 practitioners at Nutrition World, 2 medical docs, physical therapist, and all the way down the list. I talk constantly to people who are struggling with health that the number one thing they need to do is create a team approach. You do not look for one single person to give you advice. You need somebody perhaps for exercise. How do I eat healthy? How do I supplement right? How do I think better? How do I sleep better? And this requires 2 to 4 people normally. And that's what people are learning. And I am thrilled to have the Wellness Center. Now, what is the holistic approach to healthcare? I think you kind of have an idea what that is, but it has to do with, rebalancing something in the body that created the problem to begin with. I'm always looking for the why more than I am the what. The what's important, but really you can't fix the what unless you know why it originated. Maybe it was due to being sad and depressed and anxious all the time. Maybe it was lack of exercise. Maybe it was lack of nutritional components. Maybe it was all of those above. But delving into that is not what the traditional system is really built for because of constraints of time. So that's where a team approach is important. This gentleman came to me. We have 300 people a day that actually come to Nutrition World. And he had type 2 diabetes, chronic kidney disease, and obesity. Again, I'm not treating his medical conditions. I'm working with his healthcare professionals. I'm empowering him to help his body to learn how to be healthy again instead of forcing it with changing of numbers. I want to do it in the approach that I call integrative or holistic. He was a typical American, overweight, inactive lifestyle, fully employed, and routinely goes to his regular physicians. Actually has 2 or 3. But he's been a client at Nutrition World for probably 12 years. Well, one day he decided he wanted to really get deeper into what's going on with his body because he was very frustrated. It was that sliding scale that many of us as we age can see that we're slipping down the slope of poor health and worse, and I'm not getting any better. Well, here was his cholesterol at 205, triglycerides at 120, tested on 8/12 of 2021, LDL of 131. Dr. Bailey made some great statements about the importance of managing these numbers. And he did have other factors that I'm hugely invested in. Lipoprotein A at 192, horrifically dangerous to heart disease, and homocysteine at 14.5, which should be at 8. So what do we do? Now, I will say first off, the world of supplements is pretty quite safe. Very few true injuries come from it, but it also is replete with questionable quality. And unlike a drug, a questionable drug could kill somebody. A questionable nutritional supplement means basically it won't work. There's very few, other than in the athletic field. The athletic field is where the really bad apples in the bunch are. But outside of that, it's a really good, solid industry that is checked constantly. It is not fully unregulated by any means. I've been watching the FDA for 43 years, been doing this for 43 years professionally. So we can kind of come down to a little bit of feeling of safety with it. But all these people who are your patients, they're going home and you know what they're doing. They're Googling and they're reading these people who write articles and they're trying to piece together a program. Generally, that doesn't work because the devil is in the details. You got to know what to do, how to do it, the quality of product. That's where we are the gatekeepers at Nutrition World. Nothing enters my business unless I have seen certificate of analysis, toxicity reports, everything and anything, and we're constantly vigilant on that. Well, this gentleman was okay with supplementing at a pretty therapeutic dose. And again, this was all checked out by his healthcare professional. I'm not treating him, but I'm empowering him. Nutrigold, and I'm not going to go through all this, but this product called Amla, A-M-L-A, it's known as Indian gooseberry. The most amazing product, which you will see on his blood test, that happened 6 weeks after beginning this. So basically, we put him on this list: omega-3, multivitamin, green drink, niacin, hemp fiber, hate psyllium husk. Hemp fiber is far better. Magnesium, the right kind, not magnesium oxide, which goes down the toilet and does not go into the heart. Curamed for high levels of inflammation, and berberine, which acts like metformin without all of the gastrointestinal issues. So what do? We just basically put together this and said, take it like it says on the bottle. Didn't do anything different. Okay, here we are 6 weeks later. Hey, cholesterol 159? Yes. Triglycerides went down to 84. And minus a drop of 32% on LDL, and glucose went down significantly in 6 weeks doing no dietary changes. This guy was already eating pretty well. He told me what he did. He lived on a low-carb diet, not a real keto diet. Just he was very, very choosy about his carbs that he ate, as I am. I eat very low carbs Monday through Friday. I eat 60 grams of carbs. Saturday and Sunday, I eat about 150 to 200. You have to cycle low carb or it quits working, people, let me tell you. Now, I'm a huge fan of intermittent fasting also. I'm a huge fan of cryogenics, and I'm a big fan of doing saunas. Did a float tank last night down at Lucidity. So I'm a seeker. I'm out there always looking. But this was so impressive, and it's not unusual. That's the thing. And can we do it with medicine? Heck yeah, we can. But you know, 70% of the world still uses botanical medicines. That's by the World Health Organization. And why? It works if appropriately done. It's safe, very much so, and it's inexpensive when you deal with some of the higher priced options that people may have. Now, I know some people in the health professional can't really speak about or recommend this because one is legalities and people you work for. But I want you to know that, and we're not there again to treat your patient, but if you need someone on your team, you know you can come to us. I have 4 health coaches and 17 practitioners, and we send people to the right people. It's not about how do we get money out of them. It's about how do we get them healthy. Now, I've been doing this again, 43 years this January, and my store has 8,000 products in it. And I got to a point about 10 years ago because of the continual confusion of, I will say, newbies, people who just came into the arena of nutrition and the value, what they think is the value of it, and they want to slow aging, and they want to slow inflammation, they want to live longer, they want to feel better. And it's so much of life is quality, not quantity. And I say this constantly on my radio show, on my podcast. I'm not looking to live to be 90 years old. I want quality, whatever I have left. Because we are one blood clot away from being upside down in life, even the healthiest people. So I understand that. I don't think this is going to be the fountain of youth. But I know after 64 years how it has benefited me. And not by any means am I bragging, but I have less than 10% body fat. I still can do 200 push-ups. I can do all the things I want at 64, Why? It isn't luck. It's not genetics. It is this nutritional lifestyle that I lead. But when people come in and they're like, where do I start? You have 8,000 products. It got to be confusing because we didn't have a standard because I didn't really figure it out. But when I started looking at blood work years ago, I started seeing some connections, connecting the dots. And I started saying, these people did this, and then they got this much better. And it was kind of a consistent plan that I was observing. And I wanted to create something that could appeal to 90% of everyone because we can't be their team all the time. They're not going to ask you about it probably. They don't know what to do. They're on Google. So I spent about 2 years researching and looking and connecting, came up with what I call the Core 4. The Core 4 is the program that 90% of all people and your patients, if they are on it in 3 months, you'll see changes in blood work to the positive, absolutely guaranteed. The right multivitamin, not the Centrums, not the big box. Of all the multivitamins we had, this one, Mount Angel's, the one that I chose because it is the best. I know it sounds odd, but a greens product with probiotics is a game changer. Yes, we should be eating the foods first. The knife and fork is the most powerful weapon we have, as Dr. Bailey's talked about, and many of us know. But if it was only the knife and fork, some people who do all that right are still having issues. It takes therapeutic nutrition past 50 because Father Time is cruel. Father Time actually put us on this earth to procreate, not to live to be 80. Once we're through the age of reproductive age, Father Time doesn't care about you anymore. You're disposable. I don't want that. So I'm trying to fool Father Time with the right nutrients. Green drinks do that by multiple levels that I'm not going to get into. Magnesium, 300 systems of the body rely on magnesium, and it is vital. Heart rate, blood pressure, thinking ability, muscular contractions or lack of contractions, all of that in the right magnesium, and then omega-3s, and not on this list is vitamin D. Omega-3, and we test that at Nutrition World. We have a lab there every Tuesday. It's independent. I don't own it. We don't make anything on it. People are coming in there by the droves because they want personal blood testing. And it works very well for people who want to empower themselves. Dr. Green, my co-host on Vital Health Radio, he loves it when I have people do blood testing and then send them to him with that blood work. It's really cool because it saves them money, it's highly discounted, and it's quick and easy. So going back to the Core 4, if you ever have a patient who just wants to embrace a really pretty high potency lifestyle of nutrients, and you tell them about the Core 4 at Nutrition World because that is what I've come up with that really has changed lives in a simple method. Now, how do you learn this as health professionals? Many ways. It's not super easy, but I do love the Institute for Functional Medicine. Functional medicine can have a little bit of a bad image in some people's minds, but I'm telling you, it is the future of personalized medicine because it is, as this tree shows, all the symptoms we have are the leaves of the tree. The fix is not in the leaf, people. It's in the roots. And the roots are sleep and exercise and nutrition and stress and relationships and even more than that, toxicities and helping the body to not be so acid and down the list of 25 things. So if you wanted to do on your own, you could certainly go to ifm.org and you can sign up for whatever classes you want and you can become that. I'm here hopefully to make your toolbox a little bit bigger because again, 33 to 50% of your patients are interested in what we're speaking about right here, right now. And so I am just, I'm thrilled every day to go to work because it is a game changer. There's not a day goes by that I don't have someone who cries because they finally feel like they have hope when they're sliding down that slippery slope of poor health and illness. And I love all of you, the men and women of the healthcare industry, the physicians, the nurse practitioners, and my goal is to continue to more solidify this partnership between us and all of you, because if you're here, I think you're more open-minded probably than most. And I want to thank you for allowing me this 15 minutes.
So in the spirit of the responses from last year, we're going to have a little bit of a question and answer session. So it's going to be where Jimmy grabs the microphone. You'll see him walk around with this little cube. The cube is actually a microphone that you can ask your question with. And so let me start by noting that I think Ed was the only one that actually got applause this morning. And so I appreciate the enthusiasm. Maybe we're waking up a little bit and the coffee's coming in. But, Allison and I deal with disease, patients with heavy disease and heavy problems. And so I guess my question, while we're getting the audience ready to ask questions, is when someone says to me, hey, I'm not healthy, what do I do? And I say, the first thing you have to do is really make a decision that I want to be healthy. And so these are novice people at health. They're not into exercising every day, and they don't go to the gym and lift weights and do 200 push-ups. They don't do that. So what do you tell them to start? How do you tell them, Allison, how do you tell them to start?
The very first thing is you have to do something every day. Even if you're not walking at all, if you walk 1 minute a day, that's better than 0 minutes a day. And a lot of the patients I see, because I focus on heart failure and coronary artery disease, aren't walking at all, and they struggle to walk a minute a day. So exercise is absolutely pivotal. And then really changing the way your relationship with food and how you think about food, right? You should think about food as something to make you healthier, not something to find comfort in or some of the other things that we do. And really trying to get rid of processed food. That's what I talk to people the most about. If it comes in a bag, box, or wrapper, don't eat it in general. If you get it through a window, it's probably not healthy. So you have to sort of change the way that we think about our relationship with food and think about making food as fun and healthy and enjoyable. And there's lots and lots of cooking shows online. There's tons and tons of things you can do. No matter how you eat or what kinds of food you like to eat, you can find healthier versions if you do it yourself. So I think food and exercise for me are far and away the two most important things. And then making sure you have a primary care doctor. I focus a lot on that as well.
And that's awesome. I'm a plumber. That's what I tell my patients. I fix your problems. I fix your plumbing. But I never really wanted it to be just that. And to really solve the problems for some of these patients, you have to take that time to actually talk to them about wellness and how to be healthy. And so I think that's an important concept to see. But that was a number of things we had to think about. That's maybe too much for the first guy. We'll see. We'll work on them and send them to Ed. So now we have somebody that actually wants to be healthy. Ed, what do you do next?
Well, you people deal a lot more with the crisis level than I would. They wouldn't come to me if they've just had a heart attack or if they just had some serious vascular issues normally, because that's not what I do. But when they're past that, but yet they're still struggling, I meet people individually. I think we need to, at least I have learned, I need to get the attitude, the feelings, the heart of the person, which takes some time. I mean, I'm actually now I've been booking appointments for 50 minutes. It takes me 50 minutes to really get the crux of that human. And then I know what to say. Now, I will always tell people who I obviously know that the diet is their demon, that the foods you eat are as addictive as cocaine and cigarettes and alcohol. You have to realize this or you will never change your eating habit. It's not as easy as just saying, let's choose some whole foods over than the bag of chips, because unless they understand that the bag of chips is a drug, they're not going to have the capacity to stick with it long enough. And again, I am a huge component of someone who eats a very high carb diet is going to be addicted to more carbs because of how that works in the body. And so I try to encourage healthier fats and a little bit higher levels of protein and tweaking and just giving them some tools. But they have to be ready to know that there's a dark night coming. If they cut off all those foods that they love, it's like just putting the cigarette pack down. Unless you're prepared, you're going to pick that pack back up. So I try to prepare them with some dietary changes and, again, creating a team effect, either through recommending them to go to like exercise We have a gym at Nutrition World or personal trainers. I used to think they were luxuries. I think now they could be mandatory for some people because many people simply will not go consistently unless they have an appointment and they're going to meet somebody. So I want to give them tools to enable this to be successful. And it has to be more than me just recommending it because I can't get in their head that strongly, but I can give them tools that you would, just like you would a addict who's going into rehab.
Thank you, and I think it's awesome. You know, we one of the tenets I talk to my patients about, they're all smokers. I say you got to stop smoking, and every doctor says that. Nobody tells them really how to sometimes. So the tools are what is critical for helping that patient move to that next step. So in light of any questions, we have two really amazing people up here. They're free. You can ask any question you want. Jimmy has the cube, so if you raise your hand, he'll throw it to you. And there we go. We've got a question over there. Don't beat him with it. But there it is.
So, as a primary care physician, one of my biggest concerns, or my patients' biggest concerns, are cost. So if they come, whoa, that is loud. If they come to Nutrition World and they start on your famous Fabulous 4, what's the average cost of that?
The average cost is, and we can do it less, but if they do everything I want them to do, it's $99 a month. That's what it costs. That's not super cheap, but it's not it's not unreasonable by any means in my mind. And that's really all they have to do, unless they have a specific need. Like if they're not sleeping, they may do something for sleep or if something else going on. But the Core 4 is the key. 3 months of Core 4, they will be convinced to stay on the Core 4.
And I would add, if you tell them to not eat out twice during the month and buy some food and make it at home, then they could pay for that easily.
And I would tell them that if they cut their cigarette smoking in half, that pays for the Core 4. Any other questions? Okay, thank you so much for this amazing. Oh, we have a question in the back.
Is that a microphone? Oh, hi. This is for Dr. Bailey. Can you clarify a quick question, two-part question? The effects of the recommendation to stop taking daily aspirin and an article I read about statin drugs associated with dementia.
Yeah, I think those are both great questions. So aspirin is the most used drug in the world. It's not the most prescribed drug in the world. Most people who use aspirin for primary prevention take it themselves without a doctor recommending it. So as we've studied more and more and more, we see that aspirin for primary prevention does not reduce death rates. And that means for someone who's never had a heart attack or a stroke. For someone who has secondary prevention, aspirin absolutely reduces event rates and mortality by 25 to 30%. So those individuals should continue daily aspirin. But for primary prevention, there's an offset of benefit in increases in hemorrhagic stroke and GI bleeding that diminish the benefits. And there's been at least 4 prospective randomized trials that have been performed that have shown that. So that new recommendation from the USPTF was based on data from 3 years ago. So the primary prevention guidelines had already said don't use aspirin any longer. But I think that's a great point because there's been a lot of news articles about it, so lots of patients are stopping their aspirin when they shouldn't, in the secondary prevention world. So we're really just talking about primary prevention. Statins and dementia, it's very controversial. I would tell you in the large prospective trials that have been done, there's not much data that supports that. When you look at observational studies, which is what happens in the real world, you see an association between statins and dementia, which does not get borne out in the bigger trials. Now the trials, but none of those trials were designed to look at scores of cognitive function. So all of the cholesterol trials that are ongoing now are looking at cognitive function objectively to measure that as they go forward. But great questions.
Is there a natural supplement that helps with dementia to slow the progression or anything like that?
Thank you for that. I truly believe that, one, that the body has an amazing, miraculous capacity to heal itself or at least stabilize itself, but only if we give it what it truly needs and remove perhaps what's hurting it. Now, Dr. Dale Bredesen, I'm a huge fan of his. He wrote a book on Alzheimer's, which does apply to dementia. He says there's 17 reasons why people have Alzheimer's. That's why there'll never be a drug to treat it. And we have to look at all 17 components in order to see what 3 to 5 are the most significant in order to slow this process down. We do know the brain is 50% made of fats at least, and omega-3 needs to be the primary fat that is in that. My employees, I have 26 employees at Nutrition World, 17 practitioners. We had to do a finger prick test for omega-3 for omega-3 acid index. I got all free testing for my employees. My employees eat better than probably 80% of everyone in this country. They also supplement. They usually exercise. And 70% of those were low on omega-3. And I was shocked because I assumed that taking of that one pill a day or that fish that they were eating twice a week was going to maintain it. This guessing of levels of nutrients is a joke. And vitamin D is the other issue. I have to do 14,000 units a day to be at 51 nanograms. There's another person, the next person can do 2,000 and have too much. So you have to test these things, especially past age 50. Guessing is insanity to me if you want to age gracefully.
Great questions. We're going to move on with the next section, but thank you so much for these great questions and these both lectures. Thank you, sir.